Let me go ahead and get started. First of all, some students, I don't think I've met you all before, but Dr. Raghavan, I am a kidney doctor, and I'm giving this talk. This is, I think, end of July. This is probably towards the end of the Residency Basics Series, right? Is this the last one?
Close to it. I don't know if it's the last one.
Close to it. So hopefully by the end of this month, all interns and students, anyone who's been here at least has a good overview of kind of the basic topics in internal medicine, at least to get you through the first month. So the biggest thing I'll say, if you want to re-watch some of the videos, all these are posted on our curriculum tab. So all you have to do is move over to the right side. You can click on it and watch the WebEx. Always good. Probably now you're all kind of processing things, but maybe in a month or two, it'd be good to go back and watch some of the videos, just because you have a different perspective once you're kind of like EKG. Some of these things are always good to rewatch. Fluids, hopefully, after this talk, you guys, really the objective is just to make sure that you have a good understanding of different types of fluids that we use in the hospital and why we use them. Why this is important, I think always the biggest thing is it's always the interns who orders fluids. So always the interns is definitely important to know, but certainly I think for the upper levels it's always a good refresher. IV fluids are really drugs. I think we don't always think of them as drugs, but there's so much potential harm that can come with the fluids we give, but there's also some benefit to it. So just thinking about them as the same vein as ordering antibiotics or anything else will at least give you some respect for one, the importance of fluids, and two, with the potential downside if you order too much or not enough fluid on patients. So that's really where we go. So always good to begin with the history. So IV fluids have been around for like 150 years. So 1830, I think 1450, around 1500 was the first time anyone even thought about doing any IV treatments. But around the cholera epidemic in the 1800s, that's when IVs were first really used big time for resuscitation purposes. And you can see latex solution was really the name of that solution at that time, which included some bicarbonate and some water. And this becomes important as we talk about where fluids have gone since that time. But in 1881, 0.9% saline was suggested to be the salt concentration based on some experiments, and so that's where the 0.9% for saline comes in. And about a year later, a scientist named Ringer was using all these solutions to resuscitate frogs. He found that more than 0.9% saline, actually using this fluid that comes from the water that he was doing, this technician was using, that didn't have as much saline, but it had some regular tap water, actually worked a lot better. And so he called this Ringer solution. And later we found out that the Ringer solution actually had magnesium, it had potassium, it had different salts in it. And that's where the Ringer solution comes in, is that it's not just saline, but it's a little less sodium chloride, but a little more electrolytes. And since that solution seemed to do very well, it became adopted as something to use. 1930s, the pediatrician in Hartman started to use this, and that's where the Hartman solution, so depending on where you train, you may see Hartman solution, you may see Ringer solution, but they're all more or less the same thing. They're what's called balanced solutions. So balanced solutions, they're not as much heavy in sodium and chloride. They have some potassium, some magnesium, some bicarbonate, and that's where the term balanced solution comes in. Since this time, a lot of data that we have in medicine comes from the wars. So in the Korean War, they found that when you give too much fluids to patients, they had what's developed what we now call ARDS, they had volume overloaded, they had a lot of adverse outcomes. And so that's the first time people start to realize fluids are great, they're very helpful, but if we give too much fluid, it's not a good thing. And then really since that time, you can see there's been so many trials in the last 12 years. I mean, it's really mind-boggling. It's kind of the renaissance in IV fluids. But every single one of these trials says the same thing, is that too much fluids is not good. And then number two is that balanced solutions tend to be better. So before like 2011, as I'll talk about, pretty much we're using saline nonstop. There's always a big battle between the surgeons and the internists. The surgeons would say we want to give balanced solutions. The internists would say we want to give saline, and it was kind of like a battle, which one's right, who's wrong. Nowadays, we've kind of come around to say balanced solutions are probably better for most patients. So very rarely isotonic saline is needed, but we'll talk about maybe some of the indications and when that's going to be the case. So where we are today, again, the solutions have been around for a long time. If you need chairs, you could probably grab some from in there. I told them to bring in some more chairs later on. And if anyone's not eating, there's a chair here. If anyone's done eating, maybe give up your chair. So fluids really can be bad. So let's begin with the first case. So you're a medicine intern on call. The nurse calls you about a sodium of 150. Previously it was 142. We will assume that's earlier in the morning. Patient had a stroke and seems more confused. Was receiving 2 feeds at 30 cc an hour. So just stopped pulling down. Pull out her feeding tube before you're called. So blood pressure is 130/80. Normal? Yes? No? Pretty normal blood pressure. Exam's unremarkable. So what do you guys think? So what's some of the problems in this case regarding the fluid status? What do you guys think about the volume status? Pardon? Dry. Someone said low. Someone said normal. Any takers on normal? Seemed pretty normal. The exam's unremarkable. Blood pressure is 130/80, which you all said is a normal blood pressure. So based on that, and this is a patient who's been getting feeds up until the time you were called. So they've gotten enough salt, right? Enough proteins, carbohydrates, etc. So this looks to me like the patient is probably eubulemic, would be my guess, right? The big issue is that the sodium is up to 150. So what kind of things do you think about when the sodium goes high, but everything else looks normal? Romero, what do you say?
The dehydration?
So dehydration, yeah. So that's a good call. Probably the things that I would think about is maybe insensible losses. So is this patient having a fever? Is this patient getting free water, as we say, or extra water in association with the tube feeds? A lot of times tube feeds are good, but they may not have enough water for someone who's losing a lot of extra water. You and I, when we get sodium up to 145 or higher, we get thirsty, we drink water. But someone who's had a stroke doesn't have that intact thirst mechanism, or two, they may not be able to. Obviously, they're getting tube feeds, so it's probably someone who doesn't have access to drinking water on their own. So these are all the thoughts that probably go through your mind when you get called on this patient. So eubulemic status, why she's hypernatremic. I think the big thing is this patient needs water. And again, all you're going to be deciding with IV fluids is the patient needs water and they need salt. That's really the main question. If their volume status is normal, they usually need water. If their volume status is low, they need salt. Water is D5 water. Salt is going to be either lactate ringers or isotonic. So as Nomer pointed out, hypernatremia is dehydration. I always like to say this is the nephrologist's big sticky point. I think every nephrologist's pet peeve is when you mix up volume depletion or hypovolemia and dehydration. Hypovolemia is the salt is low. Volume always means salt. Hypernatremia means dehydration, which usually means that they need actually water and not salt. So there is a difference between the two. I know everybody and their mother uses the two terms synonymously, but they are different. So if you need to give water, definitely giving it oral is always preferred. Again, we always jump to IV D5 water, and certainly in a case like this, someone who has a stroke, they don't have a feeding tube, giving it IV is the only thing you can do. But in a patient who is able to drink water on their own, always think about giving it just orally. You can give the same amount as you see here, 300 every 4 hours. Basically, within 12 hours, you're going to get 1 liter of water by mouth. That's the same as they're probably going to give over an IV at 100 an hour. But just keeping in mind that giving it oral is always better for everything. So tube feeds, why are they vulnerable? We talked about insensible losses. Osmotic diuresis, the more protein you eat, protein gets converted to urea nitrogen. Urea nitrogen is an osmotic diuretic. So the more urea nitrogen the patient has, the more it's going to run through the nephron, pull out more water, urine output will start to go up. So just think about a lot of patients who we have on tube feeds, they end up being on higher protein intake. Sometimes it's fine. You know, the nurse will say, or the dietitian say they have a lot of open wounds, they need more protein for wound healing. All this I'm not going to dispute, but the fact is that when they're on more than 0.8 gram per kilo, with 0.8 gram per kilo being the recommended amount, that means they're probably going to generate more urea nitrogen, which is going to be osmotic diuresis, and they're going to need a little bit more water. So what do you do here? So you can calculate the water deficit. I think most of us will quickly get them online. We'll find a formula. It's a pretty straightforward formula. You take the patient's sodium, subtract normal sodium, and divide it by normal sodium, multiplying by total body water, which is about 50% of your weight. And that's going to give you the amount of water deficit the patient needs. So for this patient, giving 2.1 liters, in theory, will get them back to where they need to be based on the formula. But always keep in mind, some patients have excess insensible losses. So if this patient was having fever, that means that formula doesn't know they're having fever. If they're having excessive diarrhea, the formula doesn't know that. So the formula is good, but you have to use your brain and say that if this patient's having excessive losses, then they may need a little bit more than what the formula says. And this happens all the time, because I know when I'm on nephrology, we'll do the formula, we'll say the patient needs 2 liters, we'll give them 2 liters, but then the next day the sodium is still like 150, and the reason is we're not really taking into account all the insensible losses above and beyond what they're having. So just keep in mind you may need to give a little bit more. There is a formula to help you guide how much more to give. It's the electrolyte-free water equation. I think it's a little bit too nerdy to say right now, but if you're on nephrology, I'm happy to teach you that formula. But again, for your purposes, you don't really need to know how much, except just to know that some patients may need more than what the formula says. The rate of correction, again, we'll go through this later, but typically no more than 10 milliequivalents per liter per day if you have unknown sodium. In this patient, you have a sodium within 48 hours. So within 48 hours is acute hypernatremia, and there's acute hyponatremia. In those cases, you can correct more rapidly. You get them back to normal a little bit quicker. But if you don't know what the baseline was, or it's more than 48 hours ago, you need to go pretty slow. So 8 to 10 milliequivalents per liter. And that, most of us know that for hyponatremia, but keep in mind it's the same for hypernatremia as well. In either direction you want to go, no more than 8 to 10 a day if you don't know. So the first fluid, D5 water, is isotonic, which just means it's the same tonicity as your blood. And the reason is because dextrose is a tonicity, it gives the tonicity for this fluid. You never give water by itself. So always the question comes up, well, why don't you just give water? Why do you have to give dextrose water? The big thing is, you guys remember from chemistry, if you give water by itself, it's going to rush inside the cells will lyse open. So you give it with dextrose. Essentially, as soon as you give it, your insulin should move the dextrose inside the cells, leaving mainly water in the fluid compartments. The big side effect, as you can imagine, it has dextrose, so it has sugar in it. The more sugar you give, it can cause hyperglycemia. They say if you give it 200 cc's an hour, you're going to increase the blood glucose by about 24. For most people, that's not a big difference, but again, sometimes you have patients with hyperglycemia to begin with, and just keep in mind, if they're hyperglycemic and then you end up giving dextrose water, particularly high amounts, you may cause them sugars to go even more higher. And again, sugar is also like urea, an osmotic diuretic. So the higher the sugar is, the more they're going to urinate, the more fluid you have to give, so it becomes a vicious cycle. So keeping in mind, if you're going to do this, try and make sure they're eubulemic, or at least you have a plan to keep the sugars in control. The main indication, I think, as this case showed, is hypernatremia is the main thing. Is that when you have a patient who's hypernatremic, D5 water, and they're eubulemic, D5 water is the case. A lot of times you're going to have patients who are hypernatremic and they're volume depleted. That's the most common, right? Patient who's not had any water and they haven't had any food in X amount of time. In those patients we'll get to later, you want to treat the salt problem first. You want to give them something like an isotonic fluid, like saline or Ringer's first, and then switch them to water. But for this particular case, it's pretty obvious the blood pressure is normal, the exam is normal, they were getting feeds up until the time they called you, so this is a eubulemic patient who really just needs water. So this diagram, probably our students remember much more than everyone else, but it's basically distribution of water in the body. Good to know that most of the fluid, most of the time when we measure blood pressure, we're only measuring that bottom right, which is the intravascular compartment. So we're measuring a very small amount of the fluid in the body when we check someone's blood pressure. So when you think about what fluids to give, you have to keep in the back of your mind, where is that fluid going to go? So if you have someone who's volume depleted, their blood pressure is low, you want a fluid that's primarily going to stay in that intravascular compartment. When you have someone who's dehydrated and hypernatremic, you want fluid to kind of go everywhere. They're not needing just fluid in that one vascular compartment, they really need kind of fluid in a lot of different compartments. So when you look at the distribution of D5 water, just keeping in mind of that interstitial compartment, only 1/4 is vascular, you can see that it's going to distribute pretty equally to all the compartments. So when you give someone D5 water, it's not just going to stay in the vascular compartment, which is why when someone's hypotension, volume depleted, you don't want to give D5 water because it's really not going to raise the blood pressure too much. As soon as you give it, it's going to spread out pretty evenly throughout all body fluid compartments, majority of it going into intercellular fluid, which really doesn't cause any change in your blood pressure. So again, D5 water is not the fluid you want to give someone who's crashing, they're hypotensive. Those are the patients who want to give a lot of salt-containing fluids. So just reviewing IV fluids. Again, IV fluid is two components, the solvent and the solute. The solute can include a lot of different things. Electrolytes is the main thing we're going to talk about. We'll touch a little bit about proteins like albumin. The descriptive terms typically is going to be concentrations or percent. Again, most of the time we're going to be using percentages, so probably we'll talk a little bit more about that in the next slide. But really the percentage is always grams per 100%, so grams per 100 cc's. So an example here, again, if you want to make 100 milliliters of 8% sucrose, you can take 8 grams of sucrose, mix it in 100 cc's, and then make sure that the total volume is at 100. So really, always keep that concept in mind. And this becomes important when you think about normal saline. So normal saline, which again, my preceptors always said, never call it normal saline because there's nothing normal about it. They always said to call it, so when you on, especially any rotation, but especially on nephrology, it's isotonic saline is the right word. Don't say normal saline. In fact, they used to always tell me it's called abnormal saline. It's got too much salt. That's the big thing. So if you look here, it's 0.9%, which if you remember, 0.9% means 0.9 grams for every 100 cc's. So multiplying that out by a liter, so 0.9 grams in 100 cc's gives you about 9 grams in 1 liter. So again, that's a lot of salt. Again, most of us know that we're not putting patients on like more than 2 grams of sodium per day, or 4 grams of salt per day. So then why give them this much salt in an IV fluid? So again, obviously patients you're going to give isotonic saline to probably is going to need it because they didn't have diarrhea or they've had a lot of insensible losses, and that's fine. But just putting isotonic saline on someone who doesn't need it is going to cause them to get a lot of salt buildup, and then it's going to take even longer for them to get them off. And I think all of you, at least early on, you've even seen patients who come to the hospital and they leave the hospital like 5-10 pounds heavier than they used to be. It's almost always from all the fluids that they get. So just keep in mind, we really want to be judicious about giving something like saline because it has a lot of salt in it. Dextrose is 5%, so D5 water, so that's it's 5 grams per 100 cc's, so multiplying by 10 is 50 grams per 1 liter. And again, you remember carbohydrates are 4 calories per gram, so multiplying by 4 gives you 200 calories. So 1 liter is about 200 calories of dextrose, which is probably like a candy bar equivalent, more or less. So another common misconception, people give D5 water to keep their sugar or keep their nutrition value up. And it's really, it's fine, it's better than nothing, but it's 200 calories is really not a whole lot. So just keep in mind it's not enough to keep someone from, for the whole day, for example, but giving them just a little bit of sugar. So just know it's about 200 calories per liter. All right, next one. So you're seeing a patient in ICC. Labs show potassium is 5.8, bicarbonate or total CO2 is 15. The patient's NPO all day is getting lactate to ringers, 150 cc's an hour. Patient has cirrhosis and has made less than 200 cc's of urine all day. So what do you guys think? Good touch, what do you say? What are some of the problems here?
Hyperglycemia.
Hyperglycemia, okay.
Yeah, bicarb is low. So some sort of acid.
So probably acidosis, most likely metabolic acidosis, hyperkalemia, oliguria, so less than 500 cc's a day, so it's probably AKI. Patient cirrhotic, so in your mind you're thinking, what?
No else.
Huh? Okay, so Johnson, what else? The differential diagnosis?
Acidosis.
Okay. So HRS, hepatorenal syndrome, maybe patient volume depleted, maybe patient septic, right? They have cirrhosis, they could have SVP, leading to infection. So those are all the thoughts in your mind. So what are your first steps here? Again, you're kind of thinking, what do you want to do for the patient? The big thing, like Jonathan pointed out, stopping the LR, just to think about, because the patients are getting LR 150 cc's an hour. And then we're getting it all day. So again, if you're giving a lot of fluids and the patient's not making much urine, it's really just going to accumulate in this kind of patient. They probably have overactive renin-angiotensin aldosterone system. So stopping the fluids for that reason would be important. But number 2 is just thinking about LR, what it has in it. It does have potassium, it has lactate, and lactate gets converted to bicarbonate by the liver. So in a patient with cirrhosis, who doesn't have good functioning liver, how that lactate sits around a little bit longer, it can lead to lactic acidosis. So just thinking about all that in the back of your mind. So lactated ringers, again, what's the indication for it? So we talked about D5 water is only for hypernatremia. Now we're moving into volume resuscitation. So lactated ringers like isotonic saline is mainly for resuscitation. Is physiologic, so as you see the concentration here, 130 of sodium, 4 potassium, 2.7 calcium, which again, that's elemental calcium, which can multiply, because calcium is half protein bound, and calcium is a +2 charge, it equates to about a 10 milligram per deciliter. Calcium, so kind of normal calcium levels, normal potassium levels, normal bicarbonate, because the lactate gets converted to bicarb, so really approximates our own fluid, our own plasma component. And that's why we tend to use it a lot more nowadays. So again, this has been studied for the last 15 years. Is LR better than normal saline? So in 2009, they really found there's not a whole lot different, which is what prompted all those studies. So from 2009 to 2023, there's probably at least, 6 studies, all high impact, published in JAMA and New England Journal. Like, we're talking big studies to try and figure out, is this question, is LR better than saline? We'll get to the answer, at least the answer right now. But in 2009, NS was still recommended, and later it was amended after all these trials came out. So choice of replacement fluid, typically in general, LR, I say, is going to be the most common fluid you're going to use. In patients with any kind of neurological injury, normal isotonic saline can be used because it has some vasoconstrictive properties which can help in patients with particular CNS injury, but we'll talk about that. For most of the patients you're going to see in the hospital setting, I think LR is going to be preferred in most of these studies to support that. So again, it's not shown to be superior, but you typically do have a little bit more side effects with isotonic saline. The big one being that the sodium is 154, the chloride is 154. So really the problem that all the theories are is that the high chloride is what causes all the problems. So normal chloride is like 100, 110. Isotonic saline has 154, and that chloride can lead to significant vasoconstriction, which over time can lead to AKI. So we typically don't recommend isotonic saline because it has a high risk of AKI. And that's what all the trials in the last 15 years have pointed out. That being said, LR also you have to be a little bit careful because it does have potassium in it. So someone who's not making any urine, again, we want to try and avoid giving them any potassium because they're not going to be able to get rid of it. And then the lungs we talked a little bit about, and then the liver, the big one is that if you have cirrhosis, again, lactate is good for most people who have normal liver, but lactate is a bicarbonate equivalent. And bless you, if you don't have a liver, it's just going to sit around and cause lactic acidosis. The medicine floor team. So you admit a 35-year-old male with diabetic gastroparesis and severe nausea. He's been unable to eat for 3 days. Blood pressure is 105/60. Heart rate is 110. Has depressed skin turgor. Glucose 1100. Glucose is sodium 132. You can see it looks like a metabolic acidosis. So what do you guys think? What would be some of the initial treatment? Puneet, what do you say?
DKA.
So DKA,
Fluids.
Fluids, which kind of fluids here? So were you doing resuscitation or? Okay. Replacing potassium, I think that's a good point, Jenny. Patient, as soon as you give insulin, potassium will drop big time, so that's huge on the list. But I think this patient, probably the big thing is that problem list we talked about here. Hypernatremia, again, remember you have to correct sodium for glucose. So for every 100 above 200 is 1.6 increase in the sodium.
Medical alert, stroke ER. Medical alert, stroke ER.
Is actually
Medical alert, stroke ER.
So this patient technically would have, like we talked about, it's more common, someone with volume depletion as well as dehydration, right? Because when you correct the sodium will cause 145. So we have to think about which one, but as we talked about earlier, the main thing you want to do is treat the volume depletion. So this patient, again, the higher the sugar they've had, even though they're unable to eat, so they haven't been able to take a lot. The sugar is 1100, which means they have a big time osmotic diuresis. So most likely the patient is volume depleted. Then you examine the patient, you can see heart rate's high, blood pressure is low. So this is a patient who's volume depleted. So really at this time you're thinking about, you're saying, hey, they probably have hypernatremia, but the more pressing issue is the volume depletion. So what type of fluid we're going to use? In your mind, you're thinking either ringers or isotonic saline, because resuscitation is a priority. And as we talked about then, typically giving like an isotonic fluid would probably be a good one for this patient here. Now you could give ringers as well, that's fine, I think, but these choices here, that's going to be your main one. Insulin is on there because this will come up on your board exams as well. It's always tempting to say insulin. The patient has hyperglycemia, but always keep in mind they've been living at this high sugar for a while. Volume depletion is actually the most critical one to treat. So given a choice, you want to treat the volume depletion first. If on Earth you only had two things to give them the fluids first, and then you can always give the insulin later. But don't give the insulin first because that's not the number one priority for this patient. So normal saline, again, it really says abnormal saline is isotonic. So isotonic really just means it has the same tonicity as our blood. Isoosmolar as well, pretty close. So where does the 154 come from? Again, as I said, in 1880, when the guy Hamburg was doing all the studies, he incorrectly said it was 154. But really, if you look at it, their plasma is 90% water, and that's really a lot of times what we're measuring the sodium at. So when we measure sodium 140, that's the plasma sodium. But remember, blood also has 10% cellular elements. So 10% of 140 is 14. So when you add that 14 to 140 is where you get the 154 from. And then if you do the molecular weight there, just know that the atomic weight of salt or sodium chloride at 58 grams per mole, you can calculate out to 154. So that's where the 154 comes from. Scientifically, it's not just a made-up number, but keep in mind that it is, a little bit. Well, that's why I said when you think about the harmfulness of isotonic saline, it's not so much the sodium as it is the chloride. The 154 chloride is really what people are more worried about, and that's where all the trials have suggested that the higher chloride is what leads to the AKI and acidosis. So looking at this schematic here, so when you think about isotonic saline, where is it going to go? Again, it's always going to be in the ECF. So unlike D5 water, which goes to the ICF and the ECF, this is primarily going to be extracellular. But just keep in mind that only about 25% go into the vascular compartment because that's the breakdown of the ECF. So the majority of it is going to go into interstitial spaces, which again is in the short run you give isotonic fluid, it sits there, it raises blood pressure, but over time it sits in the interstitial space, and that can lead to edema, which is why most of our patients who get a lot of salt water here, they come out with all this edema, can lead to ascites, rales, all the other complications of volume. So just keep that in mind. That not all of it is just going to go into blood vessel in the long run. So it's still one of the workhorse. We're going to use a lot of isotonic saline. Main indication, we talked about resuscitation. Some of the big side effects, like the AKI compared to LR, and this is in all the recent trials. More weight gain from fluid retention, and really the chloride is the big thing. So these are all important concepts because these may come up on your board exams, and it's just good to know. So typically when you have someone for resuscitation, I always would reach for LR first, keeping in mind if they have cirrhosis or they have oliguria, then maybe isotonic saline is important. And then the big part is that giving the right amount, not giving too much. So always when you write your orders, don't write for like 100 an hour with no endpoint. Just write for a liter, maybe 2 liters, and then reassess the patient. Once they're eating and drinking on their own, let them be the judge. Again, this is more for your patient who is really needing IV fluid at the beginning, or someone who is having such significant hypotension, insensible loss, sepsis, those kind of things where they can't really keep up. So this was published even over 100 years ago in JAMA. It said the other recklessness of salt solution, particularly in the post-operative period. So again, as we said, before the Korean War and all those studies, we're giving a lot more fluids. Now I think all of you are probably more judicious with fluids. But when I was a resident, we actually, I won't say we had paper charts, so we would just write 100 an hour and walk away, and then like a day or two later, patients would still be getting fluids, and we'd realize that nobody forgot to turn the fluids off. But nowadays, I think with electronic ordering, probably won't have any of these kind of errors. So what are equivalents? Again, this is really how elements are expressed in the body. So equivalence essentially is a way And you may be wondering, why don't we use like the charges, the +2, the -2, the atomic, the elemental charges of sodium chloride. Really the point of equivalence is that we add everything up, it should equal 0. And so where we get to this becomes a little bit important later on, is that equivalents are just the way that we do all the fluids. So when you think of sodium, chloride, potassium, just always think of equivalents more than the atomic weights. And we talked about calcium, so it's a +2 charge, but keeping in mind that, especially when you look at the 2.4 of millimole per liter lactate ringers, that actually means the same amount of calcium in the body. So even though it looks like a low number, when you multiply it by 2 because of the protein binding, and then by 2 because of the charge, it actually ends up being the same amount of calcium in the body. So that's important to know. Tonicity is a comparative term, so really I can't say any fluid by itself is tonic or not tonic. I always like to say the joke with tonic water is the only fluid out there that can legitimately say that it's tonic, but anything else, when you say something is tonic, you're always comparing it to the body. So in our body, sodium is the main force that contributes to tonicity. So something that's isotonic typically is going to have the same amount of sodium as your plasma sodium. So again, lactate ringers being around 130 to 140, and then sodium in the isotonic fluid being at 154 is pretty close. Osmolarity, this is another term to know. Osmolarity is number of particles, so it has nothing to do with charge. That's more tonicity and with the equivalence, but tonicity, osmolarity is number of particles. So you really have to add up all the number of particles in it. So again, most of the fluids, the LR, the isotonic saline, has osmolarity around 280, which is our body osmolarity, when you add up through the formula there. So all these fluids, they're isotonic and they're isoosmolar, whereas if you give something that has more particles, so like 3% saline, is basically hyperosmolar and it's hypertonic. All right, next case. So you get a call from the hospitalist to admit a patient transferred from out of town for a fall and hip fracture needing urgent hip replacement. No major medical problems. Orthopedics says will be the first case in the morning. You write the order to keep NPO. What do you guys think? The patient needs IV fluids, and if so, what fluid do you want to put the patient on? Jeff, what do you think?
Yeah, we can give them like maybe a little bit of maintenance fluids, maybe 50 cc, 75 cc an hour.
Okay, so I think the big term here, you said the word maintenance fluid. So this is something we haven't covered, right? So maintenance fluid, and yes or no. No right or wrong answer. Most of the time you guys know people go for hip replacement as outpatient procedures, and they're not, at home on IV fluids. They just show up and get their surgery. But the only thing in the hospital, sometimes the start time of the cases may be delayed. And the big thing is when you give them anesthetics, a lot of times anesthesia will drop the blood pressure a little bit. So putting them on fluid is not a bad thing. And as Jeff said, with the right amount, maybe 50, 75, 1 cc per kg per hour, this is pretty reasonable. So this one, I don't think that's the right one. Oh, that is on the choice D is the correct answer. I think the spot B is wrong. But a half normal saline with some KCl and dextrose is going to be the right thing. So again, why give any fluid? I think the big thing we talk about is if they're in the hospital and you don't know when the start time is going to be for the case, they're going to have insensible losses, NPO. We see this all the time. Patients who are NPO all day long, waiting for some procedure, and then at the end of the day we find that the procedure gets canceled. So they're going to lose fluid all day long. By the time they go to the OR, they end up being hypertensive. They get propofol, they get whatever. Blood pressure goes down. So there's really not a downside to giving them maintenance fluids. And so what do we think of maintenance fluid? D5, half NS with KCl tends to approximate insensible losses while giving, as we talked about, some calories for the patient who's NPO. And so just keep this in mind. You can run it at like 1 cc per kg per hour, around 70 cc's or 80 cc's an hour. It's a pretty reasonable amount. The only thing to think about, so patients who are in a lot of pain, you may end up with hypernatremia, because as it is, half normal saline is hypotonic fluid, so it's 75 sodium, so it's a little bit lower than your body sodium. And then again, if you don't turn the fluid off and you come back a few days later, they may end up getting volume overload because every liter of half NS is about 4.5 grams of salt. So over time, it's going to add up to the patient. But again, no right or wrong answer, but I think it's reasonable to do for something like this.
Dr. Raghavan,
Huh?
would it be wrong to give LR in that case?
You can, but again, I think for board purposes, it's a patient who doesn't need volume so much. So LR, again, LR is reasonable too. If you are going to give LR, maybe just a little lower dose. But typically, I think you want to think of fluids as either resuscitation, dehydration, or hypernatremia, or maintenance. So this would be the third bucket, which would be maintenance. So someone who's eubulemic, who really just needs something because they're not eating. So really the big thing is it approximates insensible losses. We talked about why give any fluids, and again, the anesthesia, as soon as you give the anesthetic, the patient will get a little bit hypotensive. This graph, again, really just thinks about the same thing we talked about. I don't want to spend too much time on here, but just where do fluids go? We'll talk about colloids at the end because we've talked about fluids and how it distributes through different body compartments. But when you're thinking about a fluid that just wants to stay in the vascular compartment, that's where colloids like blood or albumin are going to be your main ones there. All right, so ID service. So you're a new PGY2 resident, very confident with being a doctor now, which is always the case. You're seeing a 25-year-old patient with 5 days of watery diarrhea after camping in the Rockies. His friends barely got him back to Houston in time. So blood pressure is 105/50, heart rate's 110, poor skin turgor. You can see the labs there. So again, patient has metabolic acidosis, but anion gap is not really too high. The anion gap is around 12. So you're thinking non-gap metabolic acidosis in the patient with diarrhea. So some of the problems here, volume depletion, right? You guys clear with me? So there's a patient who's hypotensive, tachycardic. So in your mind, you know the patient needs fluids. What type of fluids would you want to give? So LR, very reasonable to do, and that's certainly fine to do. But we'll talk here about bicarb-containing fluids. So just keeping in mind, 1 amp of bicarb is a 50 cc container that has 50 milliequivalents of sodium and 50 milliequivalents of bicarbonate. So if you want to give bicarb within your fluid to patients, again, like you said, LR has lactate, which gets converted to bicarb, and that's totally fine. But someone who you think may need more bicarbonate, someone who's had a lot of lower GI losses where you lose a lot of bicarbonate, is reasonable to give some bicarbonate as well. So your options, you can give D5 water with 3 amps of bicarb, so that's isotonic, right? So same tonicity, so 150 of sodium, so 3 amps of bicarb, or you can give half NS with 1.5 amps or 75 milliequivalents. Again, these fluids are what we say is isotonic fluids that essentially give you a lot more bicarbonate to the patient. So again, if you're worried that the patient has metabolic acidosis, the pH is low, they're having big time diarrhea, so they've lost a lot of bicarbonate, then this is a reasonable option. So again, at the bottom, it's very important to keep in mind, it's very different than your patient with ketoacidosis, who has all these ketone bodies in their blood is already. So the ketoacidosis patients, as soon as you correct the underlying problem, the liver will turn all those ketones into bicarb. So they already have bicarbs floating around. This is a patient who has had diarrhea. They've lost a lot of the bicarb that they normally would absorb. So this is a patient who may have more benefit from it than anyone. That's why in DKA and some of these patients with hyperglycemic ketoacidosis, you really don't want to give any bicarb fluid because they have bicarb sitting around there. This is a patient who doesn't have that because of the pathophysiology of their disease. Other examples, so giving half NS or quarter normal saline, again, I usually don't think that it's not needed for most of the time. Again, you may see people give it, and there's nothing wrong, but just keep in mind there's really not good data to support, besides the maintenance that we talked about, just giving people half NS. I've seen sometimes in DKA, once you correct the underlying volume issue, switching to half NS by itself is a reasonable alternative, and there's some literature that supports it, but I think for right now, it's good just to think about maintenance, dehydration, or resuscitation as the 3 buckets, and then picking your IV fluid based on where the patient needs. And again, patients change. You may have a patient who you admit who needs a lot of isotonic saline or lactate ringers, and then after a day, their sodium is 150, but their volume status is normal. You switch them over to D5 water, and that's totally normal because people do change as they're here. All right, so now you're a 3rd-year resident. you're rotating on nephrology, and all you can think about is how smart these nephrologists are. And you get a consult for sodium of 102 in a patient who's altered, the weight is 60 kilos. What do you want to do for this patient?
Hypertonic.
Yeah, so hypertonic Sorrells, right? So hypertonic saline. And you want to give pretty urgently because the sodium is, 1 is 102, so less than 110, severe. But 2, the patient has altered mental status. So this is a patient who's high risk of seizures. They're having already brain swelling, which is what's causing altered mental status. So what do you call hypertonic saline? Really anything greater than the normal or isotonic saline at 308. So we typically, historically, was 2%, now it's 3% saline. 3% is basically seawater, so when you swim in the ocean, you're swimming in essentially 3% saline. You just multiply, remember, normal isotonic saline is 0.9%, so just multiplying by 3 will get you pretty close to what the sodium and chloride is in hypertonic saline. So the main indications there, really severe hypernatremia with neurological injury. So I've seen trauma resuscitations they can give because it gives a lot more volume very quickly, or it gives a little bit more tonicity, so it's going to pull more fluids in. So someone who really needs resuscitation quite urgently from a lot of blood loss. But for your purposes, the main reason to give this would be in hyponatremia with neurological complications. Big thing I would say, if you're going to order it, I don't think there's anything wrong with ordering as a resident, but just let nephrology know, especially if it's hyponatremia, just so people are on board. Always order just 250 when you can specify it in Meditech. Don't put like a liter bag because that ends up giving too much. Invariably, someone will forget and they'll get a lot. So always order just the maximum 250 cc bag. And to be honest, for most patients, average body weight, 250 cc's of hypertonic saline is the most you ever really need to give to get their sodium level up. There is the calculation. I won't run through it here because most people just put on the calculator and figure it out. But it's a pretty straightforward one. You just multiply. So for this patient, you want to go up by 4 to 6 in 4 to 6 hours. And if there's severe hyponatremia, usually you want to keep them there for a full 24 hours before one cup even more. So just plugging in the numbers there, if you want to get them from 102 to 108, you can multiply 108 minus 102 times the total body water. That tells you how many milliequivalents of sodium they need. So for this patient, they need about 180. And then you divide it by 513 because that's in milliequivalents per liter, how much is sodium is in 3% saline. And then as you know, the milliequivalents will cancel out and you're left with liters and you end up with 0.35 liters. So that's 350 cc's. Then you can just divide it by hourly rate to calculate how much you want to give per hour. You can approximate. So again, you can run at 100 cc's an hour. That's totally fine. Or you can give, some people give all 250 cc's at once and that's fine too. But the bottom line is you want to figure out how much they need and just give them that amount. Whether you give it all at once as a bolus or you give it over 4 to 6 hours, doesn't really matter. There's no data to say. In fact, some people would probably say better to give as a bolus. That way that you can correct the neurological sequelae a little bit quicker. All right, GI resident. Let me run 10 more minutes, so I'll be finished. So GI team seeing consults. I wish you could be watching the scope instead. It's always the case. You get a 50-year-old with decompensated cirrhosis, so blood pressure is 90/60. They're decompensated, which means they have complications like ascites, they have volume overload, sodium is 122, the BUN is 84. So what IV fluids do you want to give this patient? What do you guys think? Albumin? Yeah? Yeah, I think that's totally reasonable. These are all the complications in this patient, as we put here. Blood pressure. So the patient's hemoglobin 7.3. Okay, so yeah, blood is definitely a good idea. Albumin is certainly reasonable too, but hemoglobin 7.3. Most likely the patient having GI bleed, right? And that's why they're hypotensive. Certainly they could have a Prader-Willi syndrome, but I think hemoglobin being 7.3. Again, GI patients are a little more complicated. I think most of us have the rule of thumb: if it's above 7, we don't transfuse. Less than 7, you transfuse. But patients who have decompensated cirrhosis, keep in mind 7.3 is a snapshot. Next time you check it, it could be 6.4 or 4.4. They could be having big time GI losses. So if you don't give blood on this patient, make sure you're getting the hemoglobin a little bit sooner than later, because if it is lower, then we need urgent endoscopy evaluation. So I guess with this one, blood definitely makes the most sense of these choices here. Albumin is certainly a reasonable choice if you're worried about, if you know their hemoglobin is stable as well. So blood products, I think the biggest thing is it is good for resuscitation. As I talked about, blood goes straight into the vascular compartment like albumin. So if you think about it in theory, anyone who needs resuscitation, really this is going to be your best bet. But it's a precious commodity, it's expensive, that's why the blood drives all the time. And so really, just think about using it. And that's why when I was in training, I remember that giving transfusion used to be at, I think, 8 at one point. I think it was even 10 for patients who had cardiovascular disease, and then slowly this went down, and now it's at 7 is our number. So keep in mind, this is a precious commodity, and we don't give to everybody, but it does work very well for resuscitation. Albumin, again, we use albumin. Really, the important thing with albumin, the only FDA-approved indications for albumin are listed there: hepatorenal syndrome, SBP, and large volume paracentesis. So again, I've seen it used quite a bit. I've even used it here and there in these atypical, not in these presentations, but these are the main ones. And there is actually a review that was published last month in one of our nephrology journals that actually did go through all the evidence and found there's really no benefit to giving albumin as resuscitation fluid. The biggest trial was the SAFE trial in 2004 that actually looked at albumin as a resuscitation fluid and found there's really not much different and no survival benefit compared to any other isotonic fluids. I used to have done this before too, where you mix it without Lasix. Again, it makes sense. Lasix is protein bound. You want to give it to a patient with nephrotic syndrome or cirrhosis, and there's really no benefit in this trial that was done as well. So again, all these things, when we say these trials give you real world data, it gives you kind of a big picture, but again, the patient in front of you is a different patient. And in all these trials, there's always 1 or 2 people who work. So if you have a way of treating someone, they're not getting better, definitely you can think about giving a Lasix albumin infusion or something different like that. But in the big picture, it's just good to know that albumin as a fluid for resuscitation is really not any better than isotonic fluid. And like blood, it's a precious resource. It's taken from samples, and so we don't really want to give a lot of albumin unless we need to. Starches, I think really nobody is using starches anymore. At some point, it was available as a fluid, but again, mannitol also we don't really do too much. The problem with starches is the big thing side effect of one is pulmonary edema. Starches were linked to AIN and hypersensitivity reactions, so we stopped using starches in the last 10 years. But there are other fluids that are available as well. So I think this is mainly it. So the bottom line, crystalloids are recommended. And then we talked about starches on there. So last section here, so putting it all together, again, when you want to give fluids, always think, is it resuscitation, maintenance, or replacement? Replacement, I think more is dehydration or hypernatremia. And what's your goal there? Always when you give fluids, make sure you reassess the patient to make sure that you're getting to your goals. So if blood pressure's gone up, and whatever else target you're trying to fix is better. Vasopressors, I think this is more, probably you've already had this lecture from the intensivist, but once you give enough fluids, at some point you're going to say the blood pressure is still low, we need to switch them over to catecholamines. And again, that's really beyond the level of this talk, but there's a lot of point, and that's why you have the 30 cc per kg per hour, and you do resuscitation, and you can switch them over. Just keep in mind that the more fluids you give over time, the more fluids that you have to take away from the patient. So all those fluids don't go anywhere. So when you have a patient with sepsis and you give them a ton of fluids, at some point that fluids will reaccumulate and you have to deal with the complications of it. So just keep in mind at some point you have to switch them over. I think this one, I'll skip here, we talked about this already, is that just keep in mind saline has a lot of salt in it. So if you're giving it to a patient who's hypotensive, but then putting them on a low salt diet, it doesn't really make a lot of sense. So just keep in mind what we're doing. I think that's probably all I have. So really that's the conclusion here, is just learning the different types of fluids and just keeping in mind what your goal is, and then you don't want to give too much because they do have a lot of complications for it. That's it. Any questions? All right.
Back to clinic.